So you want me to remove my mask?
You may, yes.
Okay. Right. Good afternoon. I'd like to welcome everyone here this afternoon for this update on COVID-19. We're glad that you can join us. My name is Sam Penney. I'm chairman of Nespers Tribal Executive Committee, and I'll make a few opening comments, and then we're going to turn it over to Dr. Hartwig. So again, good afternoon. Reflecting on the 547 days since the Nespers tribe declared a public health emergency, I think of the range of emotions we have all experienced during this time: fear, hope, frustration, gratitude, and sadness, to name a few. However, just as important has been our compassionate response to this pandemic and this roller coaster of emotions. No matter what lens we view this pandemic through, our compassion for each other was, is, and continues to be a factor in our day-to-day survival. Compassion is something everyone is capable of and doesn't come at a cost. Compassion can have a lifelong impact and spread like wildfire. Compassion is what gives us that hope that perhaps tomorrow will be better. We still do not know how long this COVID-19 marathon is going to last, but we do know that compassion and understanding for one another is a must. We are all trying, we are all struggling, and we're all navigating a situation we have limited control over. The Nespers Tribal Executive Committee is no exception. While we fill the role as your elected leaders, we are trying to make decisions on behalf of a larger population. Although we realize we cannot satisfy everyone, all the decisions we make are meant to ensure everyone has what they need. We must keep this in mind with all our decisions, even when it comes to wearing a mask and getting vaccinated. Some might say, I'm healthy, my immune system is strong, I don't need those precautions, I'll be fine. While we hope that's true, it is not the case for everyone. The fact is that those choices, while potentially fine for you, may be to the detriment of someone else, someone who has an underlying health condition, someone who cares for the elderly grandparents, someone who has an immunocompromised child at home. While it is fair for everyone to make their own choice to wear a mask or not wear a mask, get vaccinated or not get vaccinated, the equitable choice would be to make the choice that aids in the success of everyone, or at least the majority. It should not be about politics, social status, or religion. It should be about the people helping each other, my people, your people, everyone. We have literally put our lives in the hands of our doctors at times and trusted them to help us and our loved ones. We need to have that same level of trust now that they're telling us that COVID-19 vaccine is safe and it works. For these reasons, we will continually provide support in efforts to have everyone mask up and get vaccinated. We must step up and work toward ending this nightmare together. One person can't do it alone. It will take every person, and I hope you'll join me in this proactive effort. Finally, I want to take a moment to thank the Nimipu Health staff and regional medical facilities. while most of us can never fully comprehend the struggles you faced over the last 17 months, we appreciate all your efforts, time, and dedication. The physical, mental, and emotional toll this pandemic has taken on medical personnel is immeasurable. While a thank you could never be enough, our gratitude for your commitment to serving the Nez Perce people comes from the bottom of our hearts. And I want to thank you for all that you do on behalf of all the people in our area. Kachiayo, thank you.
Thank you, Chairman Penney, for those encouraging words. The update for COVID today, I would like to focus on the current updated data and numbers, and then also reminding everybody about isolation and quarantine recommendations. And then also share with you some of our vaccination data that is preliminary through the Northwest Portland Area Indian Health Board. Let me first start by providing an update of our current case numbers. We have active case number of 26 today. We have 2.93 positive cases per day with a positivity rate of 16.60%. The vaccination data I'll review shortly. So let me first start by going over some the CDC recommendations for ending isolation for people with confirmed COVID. So for most people with current lab-confirmed COVID-19 test, and at Nimiipuu Health we're using two different types of tests. We're using a protein-based test, which is an antigen, the Binax Now test through Abbott, and we're also using the ID Now test, which is a amplification test of genetic material. So the genetic material is, or the genes that the virus needs to replicate, and the ID Now test that we've been using since the inception of our testing is that type. The Binax Now is an antigen or protein-based test that looks for a small part of the protein in the virus, not the genetic material. So those are the two test types that we're using at Nimiipuu Health. So for most people with confirmed COVID test, isolation and precautions can be discontinued 10 days after the onset of symptoms and after resolution of a fever for at least 24 hours without any fever-reducing agents and with improvement of other symptoms. So those three criteria, it being 10 days, no fever for the preceding 24 hours, and clinical improvement of symptoms are when a confirmed case can be released from isolation. And there's a 10-day isolation period. Resumption of normal activity can occur on day 11. And if symptoms are persistent, then contact tracers with medical consultation may provide an extended length of time for isolation to assure that the positive case is no longer contagious or can spread illness. I shared with you pretty early on when we had the 10 days of isolation set, where we had studies where replication competent, so the virus is able to multiply or replicate. Virus is not grown in culture after day 8 in some studies and 9 in others, which is the purpose for isolation period of 10 days. Now, there are exceptions to that. I began by saying most people. Exceptions are those who are severely ill or severely immunocompromised. In those situations, a test-based strategy may be considered, and oftentimes there also may be follow-up with an infectious disease expert, or at least consultation with. So people with severe illness requiring hospitalization, intensive care unit care, or ventilation support, which is a machine that would breathe for you, may produce replication competent virus, so virus that can multiply beyond 10 days, and that may warrant the extending of the time of isolation and precautions for up to 20 days after your symptoms start. Severely immunocompromised patients may produce replication competent or virus that can multiply and may be infectious beyond 20 days. And then they may also require additional testing and consultation with an infectious disease specialist. Infectious disease is the doctors who really only treat people with infections. And we have Dr. Souvenir in our region who we speak with often when we have questions. Those are for patients who have symptoms. For people who are asymptomatic or don't have any symptoms and may never develop symptoms, their isolation and precautions can be discontinued 10 days after the first positive viral test. Other factors such as end-stage renal disease may pose a lower degree of immunocompromised condition, but they're still included in that group. So the available data suggests that patients with mild to moderate COVID-19 remain infectious no longer than 10 days after the onset of symptoms, and most patients with more severe to critical illness or those who are severely immunocompromised may remain infectious for longer than 20 days. So people who have recovered from COVID-19 can continue to have detectable SARS coronavirus 2 RNA in their upper respiratory specimen for up to 3 months after the illness. So that means that you, even though you've fulfilled that isolation period and we don't have replicating virus, if you were to test again, you may still have either pieces of the protein in the BinaxNOW case or pieces of that RNA or that genetic material from the virus still in your system for up to 3 months. But that doesn't mean that you're still contagious or can spread the infection. So if you test and still are positive, that's not uncommon, which is why we don't generally recommend that you test. Because the infection itself poses a significant amount of anxiety and concern, and if your test remains positive, people may be concerned that they still have the infection and concerned about their loved ones that may be able to spread it. That's not the case. As your body is breaking down the virus, and as you may recall, the virus has to get inside our cells for it to multiply. It cannot live on its own. It needs our replicating information or DNA to help it multiply, and so it can't live on its own. But when the virus penetrates our cells and multiplies, when by the time it's released and you are showing symptoms, there are millions and millions of that virus that has been released for you to cause you to have those symptoms. As your body endures the infection and builds up antibodies, which are proteins that fight that infection, and breaks down the virus over time, then all of those fragments, both the DNA and the proteins from the virus, remain in your body until you can clean it up, basically. And so that is what the positive test after the infection may be present, not that you're still infectious or you can spread the disease, but that can happen as your body gets control and eradicates the infection. So there are some in the CDC update. There are some key findings from transmission literature. So the transmission is how the virus is spread. Earlier on with the novel means the new or the original coronavirus or COVID virus, there were a lot of studies about how this virus was spread, and it was primarily found to be that respiratory droplets pose the greatest risk. There was a little bit of literature or data about aerosolization, which are particles that remain in the air for a longer period of time. The mass of a respiratory droplet is such that it drops, hence the name droplet, drops because of the mass and sits on surfaces. Aerosolization particles are very lightweight, if you will, and they remain in the air longer, and that transmission has been found to be greater with the Delta variant that we have in our community. And so I'm going to go over some literature that reviews a little bit of that, but concentrations of the coronavirus in upper respiratory specimen decline after the onset of symptoms. So when your body is manifesting or showing symptoms, that means that your body is fighting the infection. Your mucosal membranes, which include in your nose, you get a runny nose, you can get headaches, you can get fatigue. Your body has now started fighting that infection, and so the concentrations of that virus decline when your symptoms start, because your symptoms are telling us that your body's doing what it needs to get rid of the infection. Several studies have found similar concentrations of the SARS-CoV-2 RNA in upper respiratory specimen from children to adults. There had been some early data that showed that children may not be able to pass the coronavirus as readily as adults, and we now have some data that shows that the kids have about the same concentration in their upper respiratory specimen. So anything above your lungs is upper respiratory, so trachea, mouth, nose is upper respiratory, and so those concentrations of the coronavirus are about the same in adults and children. And to date, most studies of COVID transmission has been found that children and adults have similar risk of transmitting SARS-CoV to others. There was a single study reported that children were more likely to transmit than adults older than 60. And we have a lot of our youth that see their grandparents and their great-grandparents often who are older than 60. So it's just important that we are judicious and cautious with our behaviors to help protect our elders. Certain coronavirus variants are more transmissible than the wild-type virus or other variants. So wild-type is the not original virus, resulting in higher rates of infection. People infected with the Delta variant, which we sequenced 2 cases in mid-June in vaccinated individuals, and both of those cases returned to be the Delta variant. So we know that it's been here at least since mid-June, and the 99% is what is of the infections are the Delta variant in our country. They're probably the same here. So people infected with the Delta variant, including fully vaccinated people with symptomatic breakthrough infections. I don't like the term breakthrough, just as kind of a side note, just because the vaccine isn't 100%. So for us to say it broke through the vaccine, there's not a full protection from the vaccine, although there's greater protection and significantly less risk of infection with the vaccine. It's not truly impenetrable, which we've seen, and that's one of the comments that people often make. Well, why should I get the vaccine? Because I can still get the infection. You can, but the risk of hospitalization and death in those vaccinated is significantly less. And I didn't say that it was zero, but it's significantly less with the vaccine. And the vaccine protects not only you, but those who are around you. So people infected with the Delta variant, including fully vaccinated people with breakthrough infections, can transmit infection to others. However, like other variants, the amount of virus produced by the Delta breakthrough infections in fully vaccinated people decreases faster than in unvaccinated people. And that means that fully vaccinated people are likely infectious for a shorter amount of time. So you may not be able to transmit infection as well, if you will, if you're fully vaccinated, which is a good thing. The likelihood of recovering replication competent or infectious virus is very low after 10 days of the onset of symptoms, except in severely ill or immunocompromised people. For patients with mild to moderate COVID-19, replication competent virus has not been recovered after 10 days following symptom onset for most patients. There are outliers that exist, and as they do with anything, and there was a single case report. A case report is a single person, not any group of people. A case report is a single case in an adult with mild symptoms who provided a specimen that yielded replication competent virus for up to 18 days. But of all the millions of cases that we've had, there was a case report of one. So that's a really small number. Recovery of replication competent virus between 10 and 20 days after onset of symptoms have been reported in adults with severe COVID-19. Some of these individuals were immunocompromised. However, in this series of patients, it was estimated that 88% and 95% of their specimen no longer yielded replication competent virus after 10 to 15 days following onset of symptoms. So detection of subgenomic, of SARS-CoV-2 RNA of replication competent virus has been reported in severely ill or severely immunocompromised patients beyond 20 days, and as long as 144 days in very rare cases. And then, as I stated before, prolonged detection of replication competent virus may be associated with other factors. So there was a 13-year-old, an example that was given was there was a 13-year-old immunocompetent male, so his immune system was functioning normally, who was hospitalized for injuries he received in a motor vehicle crash. He required intubation, so they put a tube in his throat to breathe for him, and he developed pulmonary infiltrates, which is fluid in his lungs, and tested positive for SARS-CoV-2. Viral cultures of upper, so from his mouth or nares, his nose, and lower, so they had a tube in his lungs, so they could go down into the lungs and get a sample, and those were positive on days 47 and 54 of his hospitalization. But given that he was hospitalized for 47 and 54 days, means that he was really, really sick from that accident combined, that stress perhaps from the accident that his body was enduring and trying to fight, in addition to the infection, may have complicated things significantly. The risks of transmission to others varies based on several factors, including time after onset of symptoms, the virus variant, and the virus levels in the upper respiratory tract, as well as the disease state. Are they asymptomatic, pre-symptomatic, or symptomatic cases? In a large contact tracing study, no contacts developed SARS if their exposure to the COVID-19 case patient, which is the patient who is positive for COVID, occurred 6 days or more after the case patient's onset of symptoms. So if you had exposure to a COVID positive patient at least 6 days after the onset of their symptoms, your risk of getting that is reduced than if you saw them in their pre-symptomatic stage, that 48 hours prior to the onset of symptoms, or in their symptomatic stage where they're actively spreading virus before that 10-day period. One study published in January of 2021 reported that 59% of SARS of COVID cases, if their exposure to a COVID-19, 59% of COVID-19 transmission originated from index cases that were asymptomatic or pre-symptomatic. So asymptomatic meaning not having any symptoms through that whole illness, and then pre-symptomatic is that 48-hour period prior to the onset of symptoms. There was also a meta-analysis. So a meta-analysis gathers lots of different studies. If small studies don't have enough power or weight to come to a conclusion, scientists will often group a bunch of similar studies together to get more information. So there was a meta-analysis published in February of 2021 that found that the secondary attack rate for asymptomatic, so they never developed symptoms, index cases was at 1.9%, but 9.3% of pre-symptomatic and 13.6% for symptomatic index cases. Therefore, individuals with COVID infection without symptoms pose a transmission risk and should isolate based upon the recommendations. When your symptoms persist, one of the requirements for release from isolation is improvement of symptoms, not complete resolution. So for the example, the loss of taste and smell may continue for weeks or months after recovery from an infection. And the presence of these symptoms it does not mean that the isolation period must be extended. It means that your recovery from that and the neurologic impacts from COVID-19 have been fairly common and curious. Nobody really truly understands why the nervous system was affected so greatly, at least I'm not aware of that. But that regeneration happens in a delayed fashion or may take a long time for that to happen, but it doesn't mean that you're still contagious and that you should be still in isolation. There are some limitations to what I've explained. The studies referenced may have differences compared to the current epidemiology in the United States, because many of these references involve non-U.S. populations or homogeneous populations, meaning all the same people or ages. Virus transmission prior to the availability of the vaccine. So some of the data is pre-vaccine data, and infection prior to known variants of concern, such as the Delta variant. So we're gathering and reviewing data as it's available, but it takes time and is somewhat delayed. So hopefully you all clearly understand when isolation can be discontinued and what we can do to help be confident in knowing that isolation can be ended at 10 days and who it should be extended in. I've been looking at our cases and the breakdown of the tests that have been conducted at NIMIPU Health for the month of September. And one of the things that I've done is we've looked at our rates of infection in those vaccinated and unvaccinated. And as of the 17th of September, for every one case in a vaccinated individual, we are seeing 8.2 cases in an unvaccinated individual. So that there was a more than 8-fold risk of having COVID, at least per our data, if you were unvaccinated than if you were vaccinated. And we have had days where 100% of the cases have been in unvaccinated individuals. I also looked at the age breakdown of tests that were conducted and their associated positivity rates. So in September to the 17th of September, we had conducted 287 tests. 101 of those tests were in children aged 0 to 12, so those who cannot be vaccinated. Really, it's 0 to 11 that can't be vaccinated, but 12 was included for this data set. And that represented 35% of the tests that we conducted. Of those 101 tests, 21 of them were positive, which came out to a 20.7 positivity rate. The 13 to 18 year-old group had 23 tests, and 3 of them were positive for a positivity rate of 13%. But the 0 to 18 cumulative tests, of the 287 that were conducted, 124 of them were in that 0 to 18 age group, our school-age children or Head Start-age children, and that represented 43.2% of the total tests that we conducted. In the 19 to 30-year-old, there were 32 tests of the 287, which represented 11.1%, and there was a single case which represented 3% positivity rate. The 31 to 50-year-olds, we conducted 74 tests of the 287 for a percentage of 25.8%. Of the 74, we had 14 positive cases for a 19% positivity rate. And then the 51 to 64-year-olds, we had 32 tests that were ran. Only 3 of the 32 that age group of the 32 tests were positive for a 9.3% positivity rate. And those 65 and older, we ran 25 tests of the 287 for 8.7% testing rate, and we had 3 positive cases for a 12% positivity rate. I think that these numbers lead us into our vaccination data, and this is all preliminary, but I will share what I have. So for the Lapwai Kamiai clinics, the patient vaccination status, those who are fully vaccinated are 39% of our patient population. Those who don't have a vaccination record are 59%. 3% are partially vaccinated, and 1% of them, of the vaccines, were completed outside of our clinic. The percent of patients fully vaccinated with each age group, and this data is from December 21st, 2020 to July 31st of 2021. For the highest group that was vaccinated of our patients was the 65 and older group. 69% of those patients were fully vaccinated, followed by the 55 to 64-year-old group with 49% vaccination. The 45 to 54 age group has 44% vaccination status. 35 to 44, 30% vaccination status. 25 to 34 years old, 24%, and 18 to 24, 20%. And then 17 and under, for a significant amount of portion of that time, we weren't able to vaccinate anybody under 18, and that represents 14%. 99% of the fully vaccinated individuals are Native. We did vaccinate some non-Native community counterparts and partners, and 1% were non-Native. Of the staff at Lapwai and Kamiai, Nimipu Health staff, 65% of us are fully vaccinated, 33% don't have a vaccination record, and 2% are partially vaccinated. The rates of vaccination of Nimipu Health Clinic staff by race, 70% of the fully vaccinated individuals are Native, and 30% are not Native. Of the Nez Perce tribal employees, 62% are fully vaccinated, 36% don't have any vaccination record at Nimipu Health, and 3% are partially vaccinated. Of the fully vaccinated persons, 72% of Nez Perce tribal employees are Native, and 28% are not. The Nez Perce Tribal Housing Authority, 44% are fully vaccinated, 50% are unvaccinated, and 6% are partially vaccinated. For the tribal enterprises, 40% are fully vaccinated, 56% are unvaccinated, and 3% are partially vaccinated. So we have some work to do still with the vaccinations. One other update that I'd like to share is I've been working over the last week or so with surrounding hospitals because we don't have the ability to provide infusions for monoclonal antibodies. Monoclonal antibodies, our mono is one, it's a clone of a single protein, of the S protein actually, to help fight the coronavirus infection. If you remember, the S protein is what allows the virus to penetrate our cells and get inside. So an infusion in antibodies are proteins that fight infection. So an infusion of a monoclonal antibody, it's an antibody that was made in the lab that is given to you via an IV that can act as an immune response to your body to help reduce the severity of COVID-19. So I've been working over the past week to collaborate with surrounding hospitals so that we have an opportunity for our people with mild to moderate COVID infections to go to these hospitals for monoclonal antibody treatment. We received our order of the monoclonal antibodies today, and so hopefully we can get these to our partners. The partners that I've talked with that we have order sets for are St. Joe's Regional Medical Center, Tri-State Hospital, St. Mary's Hospital in Cottonwood, and Clearwater Valley Hospital in Orfino. So my hope is that we get those allocations out for our people to be able to receive those monoclonal antibody treatments to help reduce the severity of infections. If somebody requires hospitalization or needs supplemental oxygen, these monoclonal antibodies are not recommended. There are some criteria that I'll go over quickly and briefly. We'll get this out at some point when the entire workflow and process has been outlined. I just wanted you to be aware that this is something that we have recently is available to us. So the treatment for the monoclonal antibodies is also an EUA, Emergency Use Authorization. So it hasn't been totally approved by the FDA for use, but because of the nature of the pandemic, they've provided approval for adults and pediatrics 12 years of age and older who weigh at least 88 pounds, who have tested positive for COVID with mild to moderate symptoms, but have traits that put them at high risk for progressing to severe illness. So those who are 65 years of age or older, those who have chronic kidney disease, diabetes, have a body mass index greater than 35. Tri-State has a body mass index of 25, so virtually anybody will qualify. Have immunosuppressive disease or are currently receiving immunosuppressive treatment, or are 55 years of age and older and have cardiovascular disease or high blood pressure or COPD, which is a lung disease or other chronic respiratory illness. And for those 12 to 17 of age, and they have a body mass index greater than the 85th percentile for their age and gender based on the CDC growth charts, or sickle cell disease or congenital or acquired heart disease, or neurodevelopmental disorders like cerebral palsy, or a medical-related technological dependence like a tracheostomy, which is a tube in your throat, or a gastrostomy, which is a tube in your stomach. So those are some of the criteria that you have to meet to be able to receive the monoclonal antibodies. So hopefully we can get that treatment or have that treatment available for our people. I had a couple of questions that were submitted before the live today, so I'll address those questions. The first one was new Pfizer approvals for 5 to 11-year-olds. How will Nimipu Health react to this new information? So that information is still not released. There's a lot of discussion. There's some data only from the Pfizer vaccination, not from any of the other manufacturers of the vaccination. So it's really premature. We're certainly planning, and the rollout of vaccinations, we have seen more receptivity as our numbers have climbed with our vaccination rates. But we'll certainly get it out as soon as we can when there's approval. One of the comments that I like to make about that approval, it seems like the CDC and the ACIP, which is the immunization board that oversees all vaccinations, they had been working very closely together, and now there's been some separation of parties. ACIP isn't necessarily meeting. CDC has created its own board, and that makes me a little bit hesitant. The information and release of guidance has been so cohesive, really up to this point, and when they start breaking out into smaller groups to make decisions, maybe that's because of, they're overloaded, but it makes me hesitate a little and want to look a little bit more deeply at that data and those recommendations when the parties are fragmenting some to come to conclusions and creating different boards to approve things. That my concern is that it might not be completely based on the data and science, that there may be political influences, which there's a lot of political influences with this pandemic, but it just makes me hesitate some when I start to see some boards fragment. And for what that's worth, I'm going to look more closely at the recommendations and the data before passing that stuff out. So the approval from Pfizer has not happened yet, but there's some preliminary data. We'll certainly try to get people vaccinated as we can. The next question is, what information do you have on the rare but severe effects on children? So the most common severe rare condition for children is myocarditis. And myocarditis, myo is muscle, carditis is inflammation of the muscle of the heart, and that happens at a rate of 0.0001. So 1 per 100,000 cases, and so it is rare. And in a situation where a kiddo develops that, and you can develop that from an infection or when your immune system is boosted or mounting in a response to something, most of them have been self-limited, which means that they go away on their own without treatment, short-lived, which means that they don't last very long, and none of them, per my limited data review, have showed any associated coronary artery abnormalities. So the coronary arteries are the blood vessels in the heart, and we look at them often with things like Kawasaki's, where you can get dilation of a coronary artery, and that can rupture and kill you. But those kinds of complications have not been seen in the rare cases of myocarditis in children. The next question is Nimipu Health administering the booster now? If not, when will they begin? So the boosters, there's a lot of information. I met with our chief pharmacist today to discuss and review information and data and recommendations. And the booster, for clarification, is the third dose of an mRNA vaccine for an immunocompetent patient. So somebody whose immune system is functioning normally, that is what is termed a booster dose. Those who are immunocompromised have been recommended to get a third dose. So though the third dose has been approved and recommended, the booster dose has not yet. There's lots of conflicting information, which is when I went to look up the information to get updates about booster, that's when I saw the fragmentation of all the different boards and reviewing and approving the vaccine, so that's what makes me hesitate. But the booster has not been approved. The third dose for immunocompromised patients has, and that's being administered now. If you have an immunocompromised illness and you haven't been contacted by us, we're functioning off of a report based on patients who have or who meet current diagnoses. But if you have an immunocompromised state and have not received your third dose, please contact us and we can get that administered. Are there any questions? So the first question is, those that were vaccinated and got infected this year, did they have COVID last year? I have family who did not have COVID last year, got vaccinated, and got COVID this year. So the from the data, those who were, we only found one reinfection, and this is preliminary, but we found one reinfection, and that patient was not vaccinated. We have not seen any repeat infections in somebody who has previously had COVID and received a vaccination. Is the tribe in Nimipu Health going to mandate all employees and all programs, Nez Perce Tribal Housing Authority enterprises, to get vaccinated? We've discussed this significantly in our EOC meetings, and it's my personal recommendation that we don't get vaccinated, and really because any type of medical treatment should be discussed between you and your provider.
But we don't
Mandate vaccinations. I'm sorry, what did I say? We give vaccinations. Please get them. But mandate vaccinations. Thank you, Keilani. Mandating a medical treatment, in my opinion, really encroaches on the doctor-patient relationship. I have provided exemptions from vaccinations after discussing and answering questions, thoroughly educating my patients about the benefits of it, because there are a lot of, in this media-laden environment, there's a lot of information about a lot of different things from a lot of different sources, and I would like for you to be fully informed, have your specific questions answered, help you understand to have you make that informed decision. And I've used the example of a terminally ill cancer patient who's hospitalized but still wants to be resuscitated if their heart were to stop or they were to stop breathing. So have CPR done to get their heart to keep pumping and put a tube down their throat to help them breathe. That decision is not mine or anybody else's, in my opinion, to make. If that patient's able to make decisions, even if they have cancer fulminantly spread in their body, and if their heart were to stop, they want us to perform CPR to help keep them alive and put a tube down their throat, my obligation as a clinician is to follow their wishes. For me to mandate a medical treatment in that situation, and if that case is futile, so we did CPR, we have them on a vent, if we did a brain study to find that they don't have any brain activity, if I deemed that case futile, if I was caring for that patient in the hospital, I have to get another doctor's opinion that, yes, it's futile, okay, let's stop care. I can't independently just stop care in that situation. That has to be made with collaboration with another provider, with another physician, or the family has to direct us to do that. So I feel that the vaccine mandate really encroaches and forces my hand as a clinician, which nobody ever should, to perform a care measure that I might not feel is appropriate. So if a patient came to me and had anaphylaxis from every vaccination that we gave them, I wouldn't say, here, let's give you the COVID vaccine. I would say, do you have family members that are close to you? Let's get them vaccinated to help you. And I've done that in situations with COVID. We had an Alzheimer's patient who couldn't make her own decision. Family was concerned about her getting the vaccine. And I said, well, let's not vaccinate her, but let's get everybody around her vaccinated for her protection. So that is my personal stance. I don't make the decisions for the Nez Perce tribe or the enterprises, but that would be my recommendation from a clinical standpoint, is that encroachment into the doctor-patient relationship not happen, and that relationship be respected, for people to be able to openly get information about the vaccine and their hesitancy, and provide information. Like, people are like, oh my gosh, this is produced in 8 months. How can we trust something like that? Well, actually, the mRNA data goes back to, the earliest point that I could find was 1960, but the more recent routine study of mRNA science was in the 90s. And I graduated in the 90s, so that wasn't that long ago, but 30 years ago. So it's been around for a long time. That's the point of my comment, is that the mRNA science has been around for a long time. So it wasn't just found 8 months ago and now we have this vaccine. The mRNA, there were bits and pieces of it throughout the science history, where we found that we could envelope it in this fatty sac to allow it to penetrate the cells. Well, that was a huge portion in getting this vaccine developed, and that wasn't in the last 5 years. That was in I think it was in 2007. I should have jotted those dates down when I reviewed the article, but it was in the early 2000s. So the mRNA science has been around for a long time. The application, the ability to apply it to a specific disease, COVID fit very well with that spike protein on the surface of it. That allowed us to use science that we had had around for a long time. So that was a long answer for will there be a mandate for all employees to be vaccinated? My professional opinion would be no, but the policy makers really are going to carry out that recommendation. But I would say that encroaches on the doctor-patient relationship, which should be sacred. The next question is, I was tested 3 times, and one test used on me was positive. The nurse wasn't sure, so made me test again. If one test isn't accurate, why use it? How many people were given inaccurate results? So we will use in clinical circumstances where there's question about accuracy of the test. In one situation fairly recently, there was a test that had come back positive, and all of those around this positive case were tested and were all found to be negative with symptoms. We have seen other viruses that very closely mimic COVID in this past month. So when we saw that symptoms were all similar, one faintly positive case, and any faintly positive case we term positive, okay? All of the other tests around that case were negative. That makes me question whether or not that positive was truly positive, which is why we would employ another test. And using another test, we would first test with the protein. So we have, of the testing kits, we have a significantly higher number of the Binax now, or the protein test, than we do of the ID now. Now, we don't have shortages of either, thankfully, but when we're deciding which test to use. The Buy Next Now is less labor intensive. It's been as accurate as the ID Now test, and we have more of them. So we're going, and they actually expire a little bit sooner. So we're going to use those tests. But in circumstances where a test is positive and there's clinical information around that case that makes us question, what I'll often do is I'll recommend that we retest with the test that was used, and that was negative. And then we test with the ID Now test to find out if there's genetic material that we can amplify. And so it's not all straightforward in those situations. We try to take the big clinical picture in mind to make sure that we're protecting everybody around you and in our community the best that we can. The tests are accurate. That the circumstance that I'm thinking of was the only, of all the tests that we've ran, was the only one that was a false positive of as I said, all that we've run. And I'm trying to find a cumulative number of tests. Of the 3,658 tests that we've ran, there's been one that I've questioned. So the test is not inaccurate. The clinical circumstance made me question, and so we retest in that circumstance that I'm recalling. Any other questions? Okay, there's one last thing that I like to cover. NIMIPU Health is offering flu vaccinations when we're starting the vaccine distribution on October 18th. I know that there have been some that have been given out prior to that date, but we're starting to distribute to the community on October 18th. And the reason for us waiting until the 18th of October to distribute them is that our flu season generally flows into March and April, and that flu vaccination is only good for about 6 months. So in order to cover that tail in March and April, we don't start distributing until mid to late October. So remember that. And the entrance for vaccinations with the pharmacy remodel is in the back of the building, and those doors have a key lock on them, but they're open. So please bear with us while we're dealing with the pharmacy remodel. It's going to be an amazing addition to the clinic when we finish, but there's some growing pains that are going to happen for the next 6 to 9 months. So be patient with us, but if you want a vaccination, please go to the back of the building. And we realize that parking's an issue, and we're doing what we can to address that as well. The last thing that I would like to remind you is that there is help for those who are in isolation or quarantine, and our EOC team can assist with essential items for families in need. The contact information, the response will depend on time and volunteer availability. So the EOC assistance is really all volunteer. So we ask for patience in that response. We also ask that you designate a family member or friend who's not in isolation or quarantine to do your shopping for you. If you don't have anyone to designate, then we may have volunteers to assist you. Please make your requests Monday through Friday, 9 to 4 p.m. I know this isn't ideal, but this is how we're coordinating that to provide assistance. Deliveries may occur on evenings and weekends depending on our volunteer availability. So if any of you want to volunteer to help us distribute and help others in the community, we're welcome to your assistance. All requests require NIMIPU Health Care Professional or designated healthcare professional verification. And the number to call is, and we'll post this, is 208-790-7343. And you can also email npther emergencyoperations, all one word, at nespers.org. All right, thank you for joining today.